Welcome to The Explainer. Okay, we're jumping right into a hyper-dense clinical gauntlet today. We are shifting into high gear to master the absolute decision boundaries in head, neck, and ocular emergencies. Look, when a patient rolls into the emergency department with a rapidly expanding neck mass or sudden blindness, you literally don't have time to second-guess yourself. You need to know the raw anatomical boundaries and the exact clinical variables that dictate life-saving interventions. So buckle up, because we're going to navigate the razor-thin margins between routine management and catastrophic failure.
Here's our diagnostic triage board for today. We'll be hitting 4 main stops: airway forks and neck spaces, the acute vision loss matrix, head and neck clinical traps, and finally, clinical reconciliation and mitigation. Let's get right into it.
Section 1. Airway forks and neck spaces. Navigating impending collapse. Let's start with the absolute highest stakes, immediate mortality risk out there. Deep neck space infections that force critical airway interventions. When the airway is on the line, your diagnostic precision has to be absolute.
Now, what's really fascinating here is the raw anatomical divide between a retropharyngeal and a peritonsillar abscess. Check out the variables. Peritonsillar abscesses typically happen in patients older than 10. They show up with that classic muffled hot potato voice, trismus, lockjaw, and crucially, the uvula is actually physically displaced to the opposite side of the affected tonsil. On the flip side, retropharyngeal infections usually strike younger kids, typically between 6 months and 6 years old. And pay close attention to their positioning. These little patients are forced to lie supine and actively extend their necks just to pull in a breath. Flexing their neck or sitting up actually makes their symptoms worse.
So here is the absolute crucial point: this exact anatomical boundary. When you're looking at a lateral neck X-ray trying to diagnose a retropharyngeal abscess, you're looking specifically at that soft tissue plane. Normally, that soft tissue should be less than or equal to half the width of the corresponding vertebral body. But if that soft tissue plane is greater than 50% of the vertebral width, well, you've crossed a diagnostic red line. That right there is your radiographic confirmation of a retropharyngeal abscess, and it means airway compromise is imminent.
In this image brilliantly illustrates another truly terrifying airway obstruction. Take a look at this lateral neck X-ray. You're seeing the classic thumbprint sign of acute epiglottitis. See how that swollen, enlarged epiglottis is completely obliterating the valleculae, that space at the base of the tongue? Clinically, these patients are going to be leaning forward in a tripod position, drooling, and looking highly toxic. And here is the massive trap you have to avoid. You absolutely must not examine that throat without an anesthesiologist or otolaryngologist right there in the room. Why? Because agitating the patient can trigger severe laryngospasm, causing a complete and immediate respiratory arrest. No way do you want to risk that.
All right, that brings us to our first clinical variance box, Ludwig angina. In this condition, the singular, low-frequency variable is a rapidly progressive bilateral cellulitis of the submandibular space, and it almost always originates from an infected tooth. The patient is going to have this woody induration under their chin, their mouth will feel hot, and their tongue actually gets pushed up and back. Here's why this matters so much. This exact anatomical shift makes blind oral intubation a literal fatal trap. It is incredibly difficult and highly traumatic. This choice architecture absolutely mandates a diligent, awake fiber optic intubation or a surgical airway to secure their breathing before asphyxiation happens.
Section 2. Acute vision loss matrix, vascular versus pressure disruptions. Shifting laterally from the airway, we are entering the sight-threatening ocular emergency matrix. We're looking at vascular blockages versus mechanical pressure crises.
Notice the distinct pathophysiologic fork we have here. Both of these cause sudden vision loss, but the mechanisms and the presentations, entirely different. Central retinal artery occlusion, or CRAO, presents as sudden, painless unilateral blindness. The pupil is sluggish, and on a fundoscopic exam, you're going to see a pale retina with a defining cherry red spot right on the fovea. Make no mistake, this is an ischemic stroke of the eye. Conversely, central retinal vein occlusion, or CRVO, manifests with rapid vision loss that's often associated with hypertension. But look at the eye itself. You'll see a swollen optic disc, macular edema, and extensive venous stasis hemorrhages. It's often called a blood and thunder appearance because it literally looks like a storm in the back of the eye.
Let's move over to see how this builds into a pressure-based disruption. If a patient comes in with sudden, extreme eye pain, blurred vision, and they tell you they're seeing halos around lights, you immediately need to check for acute angle closure glaucoma. On exam, your diagnostic red lines are a fixed, mid-dilated pupil,
and an eye that literally feels stony hard to the touch, alongside massive conjunctival redness. This is a severe anatomical crisis. The drainage of fluid inside the eye, the aqueous humor, is completely blocked, which causes intraocular pressure to just skyrocket. This demands immediate multi-agent intervention. You gotta hit it from multiple angles fast to drop the pressure, using medications like topical timolol to decrease fluid production, pilocarpine to increase outflow, and systemic acetazolamide.
And here is our next clinical variance box, which isolates a massive trap in the pressure matrix. If you even suspect acute angle closure glaucoma, administering atropine or any other pupil dilating drop is an absolute contraindication. Seriously, don't do it. Dilating the pupil bunches up the iris right at the drainage angle, which just worsens the block. It will spike the intraocular pressure even further and permanently crush the optic nerve, leading to irreversible blindness. The golden rule here: never dilate a hard, painful red eye. Section 3. Head and neck clinical traps. Inflammatory mimics. Accelerating right into our third module, we have to identify disruptive inflammatory traps. These are tricky conditions that mimic other severe facial or airway pathologies, and misidentifying them will lead you right down the wrong treatment pathway.
Take a look at this choice architecture. You've got a patient with jaw pain and facial swelling. Is it acute suppurative parotitis or mandibular osteomyelitis? Well, both cause jaw pain for sure, but parotitis presents with acute unilateral erythema and an exquisitely tender swelling specifically located right at the angle of the mandible. It's an infection of the parotid gland, typically driven by Staph aureus. Mandibular osteomyelitis, on the other hand, is a bone infection. While it's definitely painful, it is typically non-suppurative, meaning it doesn't usually produce pus, and it doesn't usually cause that same severe, rapid red swelling unless it is wildly advanced.
We also absolutely must factor in systemic traps. Let's say an 18-year-old gets smacked in the eye with a soccer ball. He presents with a hyphema, which is a pooling of blood in the anterior chamber of the eye. Normally, patients might tolerate the resulting intraocular pressure spike for a few days, but if that patient has sickle cell disease or even just sickle cell trait, the rules completely change. The ocular hypertension acts as a catalyst, actually inducing the red blood cells in the anterior chamber and retinal vasculature to sickle. This rapidly leads to irreversible vision loss. For these patients, an urgent surgical washout of the eye is absolutely mandated within 24 hours if that pressure isn't controlled.
Back to that facial swelling for a second. Here's the clinical variance box for parotitis triggers. What actually sets the stage for acute suppurative parotitis? Well, the exact variables that shift your management to IV antibiotics are often found in elderly patients who are dehydrated, debilitated, and have poor dentition or a lack of salivary flow. A dry mouth is basically a breeding ground for mixed oral flora and Staph aureus to just march right up the parotid duct. Recognizing this underlying dehydration trap is absolutely key to both resolving the current infection and preventing it from coming back.
Section 4. Clinical Reconciliation and Mitigation. The triage gauntlet. We have now reached our final crucible. We've looked at these isolated crises, but as we all know, medicine rarely happens in a vacuum. It's time to bring these raw anatomical boundaries together into a unified, step-by-step sequence of error mitigation.
Let's sequence a really high-stakes integrative scenario. Imagine a complex trauma or a totally undifferentiated, critically ill patient rolling in. What's your priority? First, you always secure the airway. But remember the trap. If there is woody submandibular swelling pointing to Ludwig's angina, you skip the blind intubation and go straight to awake fiber optic or surgical techniques. Second, once breathing is secured, you mitigate organ-threatening pressure. If they have a hard red eye, you rapidly lower those intraocular pressures with multi-agent drops, strictly avoiding atropine. And then only after the airway and organ viability are secured do you finalize your peric antimicrobial coverage. You target the specific anatomy, like utilizing broad-spectrum IV antibiotics for deep neck spaces or parotitis.
So as we close out this explainer, I really want you to ask yourself this. In the heat of an undifferentiated head and neck crisis, will you recognize the single anatomical variable that turns a routine procedure into a fatal trap? Will you spot that displaced uvula, the thumbprint sign, or the sickle cell trait hiding right behind a simple eye trauma? Because let me tell you, in the clinical crucible, when seconds matter most, recognizing that one shifting variable isn't just a part of the job, it is absolutely everything. Thanks for watching, and keep your clinical dashboard sharp.